Hello and welcome. I am Cassidy Avila from the Center of Optimizing Rural Health at Texas A&M University. Thank you for joining us today for our monthly webinar on improving HCAHPS survey return rates presented by Dr. Carla Wilbur from Stroudwater Associates. I am pleased to be able to introduce Dr. Wilbur in just a moment, but first I want to let you know that we are recording the webinar and we will be sharing a copy of the recording as well as a copy of the slides with you following the presentation. We will also be leaving time for questions following the presentation, but do feel free to put the questions in the chat during the presentation, and I will be sure to present them during the Q&A if you would like to do that. So now it is my pleasure to introduce Dr. Carla Wilbur. Dr. Wilbur is an accomplished nurse administrator with an excellent background in critical care, education, and emergency services. She joined Stroudwater in 2014 from Wake Forest Baptist Health, Lexington Medical Center, where she was Director of Enterprise Excellence. In this capacity, she led, facilitated, and supported the Lean Transformation Initiative across the continuum of care and health systems, and was responsible for the development, implementation, and ongoing assessment of comprehensive performance improvement and lean redesign initiatives within the healthcare facility. Carla also is a seasoned clinician and works directly with patients in the facility's outpatient surgical department as both unit coordinator and as an endoscopy registered nurse. Carla earned her doctorate of nursing practice from George Washington University. She holds a Master of Science in Nursing Leadership from East Carolina University, a BS in Nursing from Winston-Salem State University, and an Associate Degree in Nursing from Davidson County Community College. So you are in good hands today. So welcome.
Thanks, Cassidy. I appreciate it, and thank you. And for those of you who joined us for our last webinar, I'm glad you could join us again. So this presentation is around improving your HCAHPS survey return rate, and that is a very difficult subject. I'm sure all of you would agree. So if I can leave you with one thing today that you had not thought of or that you can take back and do, I will be very happy, because improving return rates for rural hospitals are a difficult task. So just to start, we will have to go over a little bit about CAHPS. For those of you who may have not joined our webinar, our previous webinar, just a little bit about what CAHPS means, and HCAHPS, of course, because we are talking about HCAHPS return rate. A little on the voice of the customer, because sometimes we don't like to think about our patients and family members as customers, but they are customers to our healthcare services that we offer. The leadership influence around our return rate, staff buy-in, that does include our providers, population characteristics, the survey size and type of survey, and then workflow practices. So what is CAHPS? So this is our consumer assessment of healthcare providers and systems. This is also part of CMS, where our patient experience surveys lie. All of our surveys are officially designated as CAHPS and have been approved by the CAHPS Consortium. And that definitely is overseen by AHRQ. The CAHPS surveys are a component of our CMS's effort to improve healthcare in the United States. So there are a lot of different CAHPS surveys. I have them listed here, but our focus is the hospital CAHPS today. The Hospital Consumer Assessment of Healthcare Providers and Systems survey was designed to produce the data about, and you'll hear this word again, the patient's perspectives of care, to allow objective and meaningful comparisons. So prior to the HCAHPS survey, there were other surveys, but they were not comparisons. There was no way to compare a survey at one hospital with a survey at another hospital. But they all use different questions, different methods, and so forth. So that's why the HCAHPS survey was designed. It was also thought that public reporting of the results would give us all new incentives to improve quality care in our hospitals. So it's going to be out there for everyone to see. So we need to make sure ours looks good. It also served to enhance accountability because of the transparency, of course, and that the quality of our health care, or the perception of our health care that was being provided, was publicly reported. And then again, our consumers invest in their health care. So if I'm going somewhere and I have a choice, I also would look at what the HCAHPS data shows about the perception of care at that organization. So HCAHPS surveys are standardized survey instruments, 29 items. Again, it's an apples to apples approach. So the basic survey has the same questions for all of the hospitals surveyed. The survey can be administered between 48 and 6 hours and 6 weeks after discharge to a random sample of adult patients. Now, in our rural hospitals, we've always recommended that there not be a sample, but every allowable inpatient should be surveyed. The survey is available not only in English, but also Spanish, Chinese, Russian, Vietnamese, Portuguese, and German. The survey was implemented in 2006, gave us all a little bit of time to get everything together, and then the public reporting of scores started in 2008. So in 2020, approximately 4,517 hospitals participated in the HCAHPS reporting, and it's thought that a little over 7,000 patients participate in surveys every day. The latest data that we have without, and I will go into a new HCAHPS mode experiment information that we have, but for overall in 2019, male only surveys were the largest amount, 74%. There's also a telephone survey, 26%, and then you have mixed, which is male followed by telephone, and then active IVR. In July 14th of 22, we did have a HCAHPS mode experiment from 2021 that was released, and it did compare the possibility of using web first instead of just mail or just telephone or just mail and telephone. And it looked like from that experiment that a web first methodology may be the potential for the future. Another reason for us to make sure that we capture our patients' contact information and make sure that it's correct. So if we have a low response rate, now what? So how many responses do we really need? Well, of course, more the better, right? We should be surveying all allowable inpatients. We don't usually in rural have a large number of inpatients, so we need to make sure that we survey or that our vendor surveys all allowable inpatients. Another thing to mention there is remembering that our volumes impact our survey responses, obviously, and our survey responses can also impact our volumes. Back to the comment I made, if patients know what your surveys say and you have poor survey results, then your volumes may be diminished because people find that they don't want to come to your organization. It may have a bad reputation. So both of these are kind of working, in tandem, if you will, and sometimes against each other. So we have to keep that in mind and make sure that we realize that the volume is really an issue for us. We want to try to target a 30% return rate on our surveys. I read something recently where NRC Health, which is a survey vendor, had mentioned that out of a population of, so let's say 1,000 potential surveys, that 278 survey responses were needed for that 95% confidence interval with a 5% margin of error. So they were looking at what is a really valid survey, how many responses show validity in our survey information. So no, we don't build widgets. We take care of patients. However, it's known that a customer who has a negative experience is highly likely to share that experience by leaving a bad review. And that's very true. If you've received any type of surveys in the past, whether they're healthcare related or if it's when you had your oil changed, many people will not respond if they have just your normal average experience, but they are very, very likely to respond if they have a bad experience. And personally, that's how most of us feel. A customer who has a positive experience is unlikely to leave a good review. That's 1 in 10. Dissatisfied customers typically tell 9 to 15 other people about a bad experience. So it's really important for us to understand that responses and bad experiences can go hand in hand. It really takes us a great deal to overcome that one really bad response, especially dealing with a low volume of responses. So there are a few things we want to consider here. The voice of the customer, that's our patients and family members, leadership influence, staff buy-in, including our providers, population characteristics, survey size and type, and our workflow practices. So a few quotes from people around the voice of the customer. And I think for me, the most important one there is the last one. The first step in exceeding your customers' expectations is to know those expectations. So we need to listen to our patients. We need to listen to patients and family members so we can make, drive improvements and hopefully impact these patients and family members enough positively so that they will send their surveys in. Our patients and families are customers and consumers. Our patients, even though they're external customers, are consumers when they're wearing their hospital gown. Based on expectations, patients judge healthcare. So what are those patients' expectations when they come to your facility, in your clinics, the ER, the hospital? What expectations do they have? Healthcare has been known as enforced hospitality. So involuntary hospitality. Not always do we plan to come to the hospital. So sometimes it's a forced situation. Results versus bedside manner. Now it's both. Patients not only want to come and receive quality results, they also expect a good bedside manner. So it's both. Improved experiences are clearly associated with quality of care and outcomes. And patients, when their customers, accept more control and responsibility in the relationship. And healthcare is moving from a provider-centric methodology, basically, to a patient-centric. So we always have to be in tune to our patients as customers and consumers. The patient also has a perception, and this is straight out of, as you can see, Merriam-Webster. So that's their result of perceiving. And as they received this survey, how did they perceive their care? How did they observe our organization? It's a mental image, a concept. They're aware of certain things that went on in their environment. Did we wow them? Or is it something that they would really like to respond with the survey? Or was it a bad experience? We need to make sure we keep that in mind. Leadership influence in our survey responses are important as well. Is your mission and vision aligned? Does the mission and vision demonstrate that voice of the customer? Are our staff members and providers ambassadors of your mission, vision, and values? That's really an important piece. Are our leaders modeling those expectations? Are the leaders rounding? Are they rounding and speaking with our patients, leaving their business card, asking about their care, mentioning the survey? The survey you may receive a survey. Please send that back. We want to know how we're doing. Do we have support for education and training? Are the expectations for excellence part of our orientation for new employees? And that would include the importance of the survey and using those keywords at key times when talking to our patients and family members. Is there an accountability structure? The importance of the voice of the customer, is that included in our ongoing evaluation processes? All of these impact the overall patient experience, which will definitely then impact your survey response and responses, the amount that we receive. So for staff buy-in, do our staff members understand the purpose? What is that burning platform? This publicly shared data? Do they really understand why we want more responses back from our patients? That's really important during the discharge process as well. And I'll mention a little bit more about that in a bit. What is the plan? Have we done education and training on the keywords at key times so that that discussion can happen while the patient and family members are there? And that they are sharing different information about our surveys with keywords at key times. Do they have the big picture? Do they know how we're using this information? The reason that we want more responses so that we can use the information to drive improvement, and so that our publicly reported data looks better on Hospital Compare. Are our staff members being part of our strategy? We need them at the table as well to help us with our strategy on our patient experience and how to improve our response rates. Are they cheerleaders for change? And then memorable stories. Our patients' comments that they make when we do receive comments on our surveys or comments within the house while they're patients, are we using those on our posters and brochures that explain our survey and how important the survey is, and for them to respond to the survey and why that's important to us? That's a really great thing to do. It really aligns the survey, the reason that we want the survey sent and responded to, and that it makes it a little bit more relevant, because these are patients that have also experienced care at our organization. Use those testimonials with your posters and brochures that explain your survey. And then, do we have ownership? Staff having ownership that's departmental specific. Have you ever used a competition between your departments on the patient experience scores, and making sure that our departments are all going through the survey process, keywords at key times with our patients and family members? Having ownership, having our staff and our providers having ownership in that process. Our population characteristics. We need to move from a think to a know. Do we know the literacy level of our community? Truly, do we know? Have we done enough research to know what the literacy level is, written and spoken in our community. That impacts how we create our discharge instructions, how we create our posters and brochures to explain our survey, how we use keywords at key times. We need to know the literacy level. We also need to know different cultural practices. There are parts of the country where there are cultural practices that would definitely impact the survey results, and our communication around the survey. Who would we communicate with within that family? There are definitely different cultural practices. Do we use materials that explain different cultures, help us to understand different cultures and how to communicate, so that when we are explaining the survey using keywords at key times, we're keeping that culture in mind? Do we have up-to-date demographical information about our community, so we know all of the demographic information that can possibly impact survey return rates? There's been some past survey data where they looked at different demographic information in relationship to the return rates. For phone only, the higher rate of return for phone only was for maternity patients and for younger patients. For the Black, Hispanic, and Spanish preferring are less likely to respond to mail surveys. So it's important that we know these things so that we can use that information to help with our survey responses. Mixed mode has turned out to be the best for all patient groups. And the current mixed mode is mail and telephone. In the future, we're hoping that that will be web, mail, and telephone for the mixed mode survey. Survey sizes and types. So keep it simple and show respect for their time. Many organizations that I have been in over the last several years were convinced, and that's not to say that that was a bad thing at the time, but were convinced that they really wanted to make their surveys more customized to their organization. So when we were there and did formal HCAHPS training, and we would talk about return rates, we would see, oh, their survey is extremely long because they're not just using the basic CMS HCAHPS survey questions. They were using a lot of different customized questions that made the survey even longer than it already is. So we want to make sure that our surveys are as short as possible. So we want to use just the survey questions that are required. And there is data that shows that shorter surveys are reliable and produce higher response and completion rates than longer surveys. In the 2021 HCAHPS mode experiment I mentioned earlier, they used groups of hospitals, and they were trying to determine how the new mode or possible new mode would contrast with the way that we're doing surveys now. So the mail only for this experiment was at 23% return, but web and then mail was at 29% return. The telephone only was 23% versus the web and then the telephone at 31%. And then the mixed mail telephone was 32% versus the web, mail, and then telephone at 37%. So it definitely looks as though using the web mode first does impact our survey response rates. So in workflow practices, We want to make sure that that we communicate the importance of surveys to patients and families by building these communications into our workflows. So we all know discharge begins on admission. So if possible, registration is a good place to start. Handing out our brochures on the survey, checking that accuracy of the contact information, which is very important and will be even more important in what they're calling HCAHPS 2.0. We want to fully utilize those admission discharge folders that we should all have that start on admission and contain a lot of different information that we need to make sure our patients have. And we want to use those as communication tools for those organizations that have mail surveys. We should add an envelope that shows the envelope that would be that the patient will receive when they get home, where the survey comes in, so that they don't think that's junk mail. It's just a copy of the envelope from the survey vendor, or however your surveys are designed, so that hey, this is the type of envelope. It's not junk mail. It's not your bill. This is what our survey comes in. The same thing for telephone surveys. We need to add the phone number of the vendor that we'll be calling, so that our patients know that that's the survey person calling, because most people do not pick up their phones if they don't recognize the number. They think it's something, spam or so. Add a letter from the CEO or administrator in the admission discharge folders explaining the importance of the survey, and that we really need to have the survey returned to us or answer if the phone, if they're receiving a phone call, so that we can drive improvement in our organization and make this a better place for you to come. Design your folder, your admission discharge folder, with the survey communication in mind. You can always have folders designed with information about the survey printed on them. In the same area where you would have who to call for what, reminding them that there is a survey and that we need them to please participate so that we can improve our practices. Include that survey information in the patient discharge education. When our nurses are discharged, we do have some hospitals that have the discharge planners do the discharge. Whoever's responsible for discharge to go back over the survey again and let them know that they'll be receiving a survey. Remind the patients about the survey during follow-up calls. Hopefully your vendor will get the survey out as early as possible. And if you're making follow-up calls 24 to 48 hours, and then possibly at 7 days, we can remind them about the survey and how important it is for them to participate. And then consider using a focus group. If you happen to have a patient family advisory council, or if you have a small focus group that you use on your inpatient side, have them evaluate your processes. Ask others about receiving a survey and what would make it easy for them to do the right thing and send it back in, or why would they not participate in the survey? Again, using that voice of the customer, try to figure out why it's is it just too much for them? Are they happy to be out of the hospital, so they just don't want to do the survey? We really need to understand what their concerns are, or what barriers may be impacting our survey response rates as well. And what to say? We should say, we love to hear feedback about the care you're receiving. You may receive a survey after you get home. It'd be great to hear how we're doing. We don't want to say you may receive a survey after you get home. It would be great if we get the highest score. or we hope you will recommend our hospital to your friends and family. We can't do that. Or we hope you will give us an overall rating of 10. That's not appropriate either. I've told the story many, many times that I had the young lady that was in charge of our surveys at my hospital. The survey rates just kept going, return rates kept going up, and it was wonderful. We thought that was the greatest thing. And I asked her, I said, and why all of a sudden we're just seeing a great return, survey return. We'd struggled with this for so many years. And she said, yeah, ever since we started sending gas cards out, if they return the survey, then we're getting more surveys. And said, oh, no, we cannot do that. We can't encourage patients to answer the survey in any particular way. And we also can't imply awards or benefits will be given if they do return the survey. That's not allowed. We wish it was, but it's not. So we can't solve our problems by using the same kind of thinking we used when we created them. So we have to think outside the box and maybe use some of the recommendations that I've outlined here for you to try to use just one or two new things to make a difference in your survey response rates. We'll open it up for questions now.
Excellent. Thank you. I don't have questions in the chat yet, but I would like to encourage you, if you have a question, to either unmute or type your question into the chat, and I would be happy to read it on your behalf. Okay, so our first question, where does the 30% target recommendation come from?
So the 30% is the target that we at Stroudwater use, but I have also read that the 30% target rate on any type of survey, and this was not just specific to patient satisfaction surveys, would be a viable type survey response. Anything less than that may not give you, good data to really count on, accurate data. And remembering that it only takes, especially with HCAHPS, and the way that these surveys are designed, that if you have one poor survey, how far it pulls your results down. So we really recommend that at least 30% response rate. Now we have hospitals that do have a lot higher response rate, and then hospitals that, and they're the same, they're peer type hospitals. They have around the same amount of inpatients, and some just do not have as much response rate as others. Many hospitals have changed their mode by understanding your population and how that's impacting your return rate. You may switch your mode. One of the hospitals I work with in one of our networks, they changed from mail to telephone, and they have really improved their participation rate. Others have switched from telephone to mail. It really just depends on your population. And yes, you will be getting a
Yes, thank you. Yes, we will definitely be sharing a copy of the PowerPoint slides, and we will also send, give us about 24 hours to get it uploaded to the website, but we will have a link for you that will be coming in an email from us. That link will go out to this recording. Do you see the next question?
Yep. So CMS, CMS accepts mail, telephone, and mixed mode and IVR to date. They do accept those survey responses, and yes, you have to have 100 survey responses in a rolling 4-quarter period for it to be in the public reporting, yes. But it can be any of the accepted modes, which are mail, telephone, mixed mode, and IVR.
Carla, is there a certain time if they're going to try a specific approach like telephone, is there a certain amount of time that you recommend they give that a try before switching to another mode?
I would definitely give that, 6 months to 9 months, 6 to 9 months. I mean, you're not going to see once you get started, your response rates are so far behind. And we can't really see things that, within that 4-quarter rolling period, they're not going to start being publicly reported. Now, you as a hospital will get your results. Your vendor should be providing you with a portal or the information in fairly real time. But I would give it, 6 to 9 months before I would say, no, that's not going to work.
Excellent, thank you. And we do have a few other questions in the chat. So the next question states, is there a number of questions within the research that says keep it under X number of questions? We use Press Ganey as a vendor, and they have the HCAHPS questions as well as other questions from PG. I wonder if that's too much.
So it's my understanding, and I know probably these vendors are not going to like me, but and I don't have any relationship with any vendor, but to participate in HCAHPS, you only have to have the questions that CMS wants you to have, and those are the base questions. If Press Ganey is adding custom questions to your survey, then you're probably paying more to have those custom questions added to your survey. I would recommend, if you're really struggling with your response rate and the survey is too long, that you evaluate removing the custom questions. I'll never forget going into a hospital with my colleague Lindsay one time, and we were talking to them about their response rate. Well, it just so happened that the entire leadership had changed. So all of the C-suite people, everybody had changed over the course of the last several months. So they were really focused on their return rate for their surveys. One of the senior leadership team members had to be in the hospital, unfortunately, and received the survey at his house and opened it up, and he was appalled at how many questions there were on that survey. Well, as it turned out, the previous leadership had added numerous custom questions to their survey. So it made the survey much, much longer. So I would suggest you look at your survey, compare it to what CMS requires for your HCAHPS. And I guess that would be a leadership decision as to whether or not you want to remove the custom questions.
Perfect, thank you. And our next question states, any idea when the web-based mode will be recognized by CMS?
No. They are hoping that it will come out for maybe a trial, is the last I read, that it will come out for a trial for 24, 26, and then start in 24 and 25, and then start in 26. But again, that is not that's not a firm date. That's why they were doing the mode experiments to see if what's going to work better. They're also considering adding additional and I don't mean, I shouldn't say additional. They're also considering adding other variety of questions. And maybe that doesn't mean that they're going to be more. It could be that they take some off and replace them with something else, because they're just looking at trying to make it a little bit more up to date. It hasn't been updated in a long time. They did remove the pain management question years ago. And since then, they really haven't done any more, anything to update it. But they are definitely headed down the pathway of HCAHPS 2.0 being a web-based version, having the option of web.
Excellent. And the last question I have in chat states, do you know, has there been any discussion about adding swing bed patients to the denominator? We have a small volume of IP, but a large volume of SSB.
Oh, heavenly days. If I could encourage them to add swing bed patients, it would be a glorious thing. But at this point, no. It's still, HCAHPS is still inpatients only, no swing bed, no OBS, and they have to have that one night stay. So there has not, now there are a lot of people that have been pushing for it, for swing beds to be considered in HCAHPS, but that at this point, they have not agreed to add swing beds or observations. I think that because our rural hospitals have a lot of swing beds and observation patients, that those should be considered as well, but that's not being considered yet.
Okay, well, we still have time, but those are all the questions we have in chat for now. I did go ahead and send a link out in the chat box to everyone. That's just our 60-second survey from CORE that says, how'd you like the webinar? What would you like to see in the future? So if you have 1 minute, we would appreciate you taking that survey. And I'll give it just another minute to see if anyone's typing right now. I will remind you that by tomorrow, you should receive an email from us with this recording. I'll also include the survey link in that, as well as a link to download the slides and contact information for Stroudwater so that you can get in touch with Carla should you wish to do that. And if you think of any questions after we adjourn, please don't hesitate to send an email to Carla, to myself, and we would be happy to make sure you get a response.
Absolutely. If there's anything else that you can think about, I am available, and please feel free to reach out to me.
Okay, that's a very generous offer. Thank you, Carla. And I don't see anything else. So I think we'll go ahead and give you about 15 minutes of your time back. But we really appreciate you joining us today, and we hope to see you next month. Thank you so much, Carla. That was a really interesting and informational webinar.
Okay, great. Thank you, guys. Have a wonderful day.
Thanks, everyone. Bye-bye.